We're very lucky this morning to have Dr. Sahni here with us today. Quick intro, Dr. Sahni completed medical school at the Jain Medical College in India. She went on to complete her internal medicine training at Long Island College Hospital in Brooklyn. Then she went on to Beth Israel, where she did a cardiology fellowship. Before joining Mount Sinai, she was the CCU director at Metropolitan Hospital. Currently, she serves as an associate professor here at Mount Sinai. She is the director of the Cardiology Consult Service, and in 2013 established the first ever Cardio-Oncology clinic here in the Mount Sinai Health System. Dr. Sahni's Cardio-Oncology clinic sees over 3,000 patients annually from all over the tri-state area. In addition to her clinical interest, Dr. Sahni is a phenomenal clinical educator and is a regular favorite amongst the house staff on the teaching service. Please join me in giving a warm welcome to Dr. Sahni.
Thank you, and I'm sorry that I was stuck behind a garbage truck. Besides my disclosures, which are none, a disclaimer that the next 45 minutes or so are going to be a roller coaster ride of a lot of information that you probably never heard before, but that's why you have me as your seatbelt. So we're going to quickly divide the talk in order for simplification. We're going to try to understand what cardiotoxicity means, what we can do to early detect, prevent, and treat it. Beyond cardiomyopathy and CHF or the other cardiotoxicity, we're going to quickly touch on that. A little word on radiation-induced heart disease, some little bit stuff on bone marrow if you have time, and a few nice videos on oncological emergencies. So let's start with the horrible sting math, since we're all awake, we haven't had a coffee in the morning. Let me wake you up with a little bit of math. And the math is kind of like a sweet sour kind of potpourri, in the sense that in 2016 we had 15.5 million cancer survivors, and that's thanks to our wonderful oncology colleagues and the strides that we made in the oncological world. And luckily 70% of these people who've beaten cancer are going to live for 5 years or more. Yay! But here's the bad news. And the bad news is that you beat cancer, and if you're above the age of 50 and you're a man, there's a 50% chance, and if you're a woman, there's a 40% chance that you beat cancer, but then you're going to have to deal with some cardiovascular disease in your lifetime. And not just this. Our kids who've beaten cancer are growing up, and they're going to be our adult patients. And luckily, 80% of the children who have beaten childhood cancer are going to become adult survivors. And as of 2013, the last data that we have, about 420,000 of these kids basically are going into adulthood and are cancer survivors. And by 2020, next year, there are going to be 500,000 of these. And as per the Childhood Cancer Survivor Study, it's a pretty dismal story for these kids. I mean, not only have they gone to the horror of childhood cancer, but they're going to have a 7-fold higher mortality and a 15-time more chance of developing cardiomyopathy or CHF in their remaining lifespan. So this bit is dismal. And the third reason why I want to dwell on the math of it and why cardio-oncology is such an up-and-coming field is that so far, we've done a pretty shoddy job of it. And this is actually a 2000 study coming out of Stanford, okay? This is not a community institution. It's coming out of Stanford, where they took about 88 patients who were receiving some kind of breast cancer therapy, either anthracyclines or trastuzumab. And guess what? They started off with a baseline EF of about 60%, which, as you know, is normal. And 40% of these people, after they had completed their therapies with anthracyclines, Herceptin, or both, ended up having a decline in LVEF to less than 55%. But guess what the bad number is? Only 40% of these people were put on an ACE inhibitor or an ARB. Half of them were put on a beta blocker, and only half of them ever saw a cardiologist. So this is a pretty shoddy job, and this is not like, early 2000s. This was less than a decade ago. And so that's why I want to take you back through the math of cardio-oncology and ancient history. And unfortunately or fortunately for you guys in this room, there's a lot of data to go through, right? So I'm going to start with a flashback to the 1960s, when these beautiful, by the way, my photograph of the Adriatic Sea, where basically we discovered Streptomyces pictus. A little bit before my time, but hey, in 1960s, the Streptomyces pictus was isolated, from it was isolated Adrioblastina, which was initially thought to be an antibiotic, right? But hey, we discovered it for its oncological properties. And it was initially named Adriamycin because we thought it was going to have antibiotic properties. Turned out to be an oncological drug. And so remember, mycins are antibiotics, so we renamed it doxorubicin because it's not an antibiotic, it's an antineoplastic agent. And that's where our oncological journey started first. And so Fast forward a couple of decades, we used anthracyclines for breast cancer, a lot of solid tumors, and we used it beautifully. We save people from cancer. We use it indiscriminately. We use low doses, high doses, and we saw this data from Von Hoff et al. And he started observing, and remember, this is pre-echo data. So these are people presenting with clinical heart failure, florid heart failure, right? So he started noticing that, hey, the higher the doses I give of anthracyclines, these people are developing heart failure, clinical heart failure. And in the 1970s, he thought the cutoff number was 550 milligrams per meter squared. So, hey, if I bombard them with more than this 550 magic number, they're going to develop heart failure. So let's try to limit it to lower doses, yeah? Fast forward a couple of decades more, and this is data out of MD Anderson et al., and they said, it's not 550 milligrams per meter square. We're starting to see cardiotoxicity. And now, this is echo era. They're more vigilant. They're more aware of the cardiotoxicity of adriamycin or doxorubicin. And they start saying, well, you know, the cutoff number is probably 450 milligrams per meter square as a cumulative dose. If you bombard people with more than that, they're developing heart failure. And meanwhile, we had the luxury of cardiac biopsying these people, right? Something very little in cardio-oncology now, but hey, this was, you know, echo was just emerging, et cetera. And so between 1970s, 2000, we took these people who we thought were developing, you know, cardiotoxicity, we took them to the lab and we did cardiac biopsies on them. And if this is the normal sarcomeres in the heart, we started seeing big time alveolar disruption. The cells were dying. There was line out apoptosis. Cells were dying. This was not dysfunction. This was not stunning. This was not mitochondrial dysfunction. The cells were just devastated under the microscope. And not just that, we started seeing that, hey, not even the 450 or the 550 magic number, we were seeing these biopsy changes in lower doses as low as 300 milligrams per meter square. And we noticed we were able to risk stratify and see, well, you know what, the people who were had more risk factors, had got combination chemotherapy, got radiation, these people were showing worse biopsy grades. And not all anthracyclines are the same. Some are probably less bad compared to adriamycin. And we came up with the definition of type 1 and type 2 cardiotoxicity from it. So here, the next about half a dozen slides are going to be about different mechanisms of cardiotoxicity. And what is this type 1, type 2? And this is a dated question. And again, I'm one of the people who makes questions for medicine cardiology boards, so I'm not going to defame my type. But this question is a very popular one in both cardiology and medicine boards. And they're still stuck on it. And I'll show you why it's not right to be stuck on type 1 and type 2 cardiotoxicity. But this really emerges from the earlier anthracycline studies based on these biopsy studies. And type 1, type 2 cardiotoxicity, if you really have to take home, is type 1 is a bad guy. Type 2 is a not so bad guy. So type 1 is what doxorubicin induces, the horrible slide I just showed you before, where the findings on the biopsy is outright vacuolation, sarcomere depression, necrosis, cell death, apoptosis, right? And more importantly, it is cumulative dose related. The higher the dose you give them, the worse is going to be the apoptosis. And it is irreversible. Worse is, hey, we took patients with other cardiotoxic drugs, such as trastuzumab, put them under the microscope as well. And this is the little nicer guy, the type 2 cardiotoxicity, which A, causes myocyte dysfunction. And when we put them under the slide, we do not see that horrible vascular disruption. It is not dose related, which means you can give cumulative doses. And it is basically reversible and a much better prognosis. So these are the three major differences between type 1 and type 2 cardiotoxicity. If you really have to take home a board question today, okay? So, as I said, the dose-related cardiotoxicity of anthracyclines is so magnificently related to its dose that there's probably a 50% chance. So patients come to me and say, what is my chance of developing cardiomyopathy? I'm like, it's a hard one to answer. Hopefully, in today's day and age, we're not bombarding anybody with 700 milligrams per meter square, assuring a 50% chance of cell death. But we try to limit them to lower doses. And of course, remember, this is cumulative dose. So if you had a child that survived lymphoma and was giving anthracyclines as a child, and God forbid, developed breast cancer later on, or a sarcoma, and you're bombarding them with second dose of doxorubicin, remember the clock started as a child. So they've already received, say, 250 milligrams per meter square, and you're giving them another 250, that's 500 100 cumulative exposure. So they will fall into this category, which means they have a 25% chance of developing cardiomyopathy. And not all anthracyclines are created equal. And we know this not from just clinical studies, from biopsy studies as well. So if we take doxorubicin to be the big daddy of cardiotoxicity at bolus doses of 100% cardiotoxicity, say, daunorubicin is probably 3/4 as bad in similar oncological doses. Idarubicin is probably the best, and in a lot of my leukemia lymphoma patients with cardiomyopathy, have a conversation with my oncology colleagues and say, hey, the oncologic benefit, if idarubicin is a little bit better, you really need an anthracycline regimen, this is probably a better choice. Epirubicin is also less than compared to doxorubicin, and the way in which you infuse the anthracycline also makes a difference in the cardiotoxicity. Now, a horrible, busy, basic science slide, but stick with me through this. And the mechanism is important because if we're going to talk about prevention and treatment, we need to know how this drug kills the cells. And so for the longest time, we thought, there are two theories on the slide. So let's go with the old theory first. So we, for the longest time, thought that doxorubicin combines with a ferrous moiety and becomes this doxoferrous moiety, which is able to penetrate the cell membranes and get inside the cardiac sarcomere. It's able to lipoperoxidate and get inside the cell, and here it's able to generate this horrible compound called doxysemiquinone, which is basically responsible for the radical oxygen species, and it basically leads to mitochondrial disruption. It disrupts the NOS pathway, affects the contractile apparatus, affects the sarcoplasmic reticulum. All this is from this bad guy called doxysemiquinone. And so we thought, hey, if we prevent doxo from attaching to this ferrous moiety or take away or chelate this ferrous moiety from the doxo, hey, it can't enter the cell, and even if it does, it's not going to generate the semiquinone molecule, and hey, we can stop the disruption of this cardiotoxicity. However, and we know from animal models as well as interventions, that more of the cardiotoxicity is through this guy called topo-2b. Now, there are two kinds of topoisomerase 2 molecules in our bodies. There's topo-2a, which is present in cancer cells, and this is what the anthracycline, the doxorubicin, goes and sucks to and kills a cancer cell. So we need the topo-2a action. Unfortunately, it's a topo-2b action, which is the bad part of it, because topo-2b is present in our hearts. And it's present in our hearts normally. It's needed for MRA, unfolding, et cetera, normal replication, synthesis, et cetera. But the problem becomes when topo-2b attaches to doxo, that's when all this bad stuff happens. And we know, to simplify the slide, this beautiful molecule is a topo-2b, which is present normally in our cells like cardiac myocytes. It's required for normal transcription and replication, right? The normal stuff that we need for cell turnover and repair. But when it attaches to our bad guy anthracycline, then it runs amok. Then it starts basically resulting in DNA double-stranded break. It activates the reactive oxygen species, mitochondrial dysfunction, and leads to cell apoptosis. So if somehow we can prevent anthracyclines from attaching to topo-2b and let it do its normal job and not the disruptive job, well, we can probably interrupt this cardiotoxicity cycle. And that's what this drug called dexroxazone does, which technically is an ion chelator. And we earlier thought that that ion chelation model was why it was disrupting cardiotoxicity. But now we know from animal studies and by measuring topo-2b levels in patients with cardiotoxicity that dexroxazone disrupts this unholy matrimony between adriamycin and topo-2b and interrupts the cardiotoxicity. So maybe future research, ongoing research, that maybe some people have more topo-2b in their hearts and maybe are more susceptible to cardiotoxicity and hence might benefit from prophylactic dexroxazone. How does trastuzumab, the type 2 agent, act, right? Remember the slide where I showed you it was a good guy, where it doesn't cause a vascular disruption? Well, it's a slightly less bad guy, and it becomes a bad guy only when it's in bad company, and that bad company is anthracycline. So let me walk you through this slide that, hey, I bombarded somebody's heart with anthracyclines. It started degenerating and oxidative damage, all that horrible slide that I showed you, and apoptosis, necrosis starts to happen. Well, you know what? A heart has regenerative and repair mechanisms, and these happen through something called HER2 upregulation, which helps in the repair mechanisms of our heart. All good news, which means not everybody develops cardiotoxicity, and even if they do, our heart does have some repair mechanisms in place. The problem becomes if somebody who's been pre-treated with anthracyclines and is starting to undergo subclinical or clinical apoptotic necrosis, and I bombard them, or rather my oncology colleagues bombard them now with trastuzumab, in that case, remember, trastuzumab is a HER2 receptor blocker, right? So my heart is full of HER2 receptors trying to regenerate itself from anthracyclines, and I went and double whammied it with trastuzumab. And there goes my HER2 upregulation repair mechanisms. So it's not that the trastuzumab is killing the heart cells or causing cell dysfunction. It is, we've seen not just in animal models, but we've seen in clinical trials with neoadjuvant therapy that trastuzumab-induced cardiomyopathy is less than 1 to 3%. But it's hearts that were pre-treated with anthracycline and have started the cycle of apoptotic necrosis and were HER2 upregulated. These are the hearts that basically are susceptible to trastuzumab. And the gamut doesn't run through, it doesn't end there, right? So going beyond the anthracyclines, we have a whole slew. And again, as I said, it's a roller coaster ride. Do not obsess and start taking down stuff. My slides are available to you guys. I'm available to you guys. So don't get into the system of, oh my God, I have to remember the 500 drugs that cause cardiomyopathy. But I just want to put these slides out there just to alert you to the fact that it's a beyond trastuzumab and anthracycline stories today, and I will take you through that roller coaster ride. And how do we define cardiotoxicity or drugs causing heart failure? Well, we have a clear definition, and again, there's a lot of bickering between different societies, and I'll show you the bickering as well. But as of 2014, the American Society of Echocardiography, since we use echo as our baseline of calling somebody as having heart failure from chemotherapy, defines, fancy term, CTRCD, which basically means cancer therapeutics related cardiac dysfunction. Because cardiotoxicity is too broad a term, right? Cardiotoxicity could be hypertension, QT prolongation, thromboembolism. So let's just stick to the heart failure component first. And so CTRCD, now this is important, and again, this is it's a definition that you should remember, needs two things. First of all, your LVEF with chemotherapy should decline by more than 10% points over the patient's baseline. And it has to decline to a value which is below the lower limit of normal for your lab. So our lab, as you know, uses 55% as a cutoff for normal. So if somebody's EF was, say, 75, and now the next echo says 65, and I'll come to that, that's not cardiotoxicity because the EF is still above 55. So you have to have A, decline by more than 10%, to a value of less than 55% or the value of your lower limit of normal for your valve. And so pretty much Mayo Clinic, ESMO, ASC have a similar guideline. So let's start with the bad guy, type 1 or anthracycline cardiotoxicity. So your initial evaluation, everybody gets an echo. Okay, everybody gets an echo. And so Mayo Clinic uses 50% as a cutoff for their normal, so say 50, 55, whatever your lab is. And so you start with a normal echo, you start anthracycline therapy. Now remember, this is dose related, type 1. So for every increase that you exceed beyond 300 milligrams per meter, so remember, we got that from the biopsy data from Billingham et al., we need to reassess the LVEF with a repeat echo. So every time you dose escalate by 50 milligrams per meter square above 300, we reassess with a repeat echo. And if, definition of CTRCD, if the EF declines by more than 10% to a value less than 50 or 55, as the case might be, you stop the drug. Remember, this is irreversible. It's cell death. You stop the drug. If, however, your EF was bad to start with, now that's a whole different ball game. And again, I don't completely agree with this. Nothing is set in stone, okay? If a patient has 6 months to live without an anthracycline-based chemotherapy, this is the conversation I have with my oncology therapists, the people that, are we going to do this? Are we going to prolong life by 6 months or 6 years, or are we going to kill them in the next 1 month? So this is a risk-benefit tailor-make thing that you have to do. Versus trastuzumab, where, remember, this is type 2, a little bit better cardiotoxicity. Everybody gets an echo at baseline. You start trastuzumab. Now here, you, as per the FDA guidelines and from our studies of neoadjuvant trials, you reassess the LVEF every 3 months. So everybody gets an echo at baseline, and every 3 months, and usually trastuzumab for HER2-positive breast cancers, et cetera, run for about a year. So you get an echo at baseline, and every 3 months, And here's where there's a little bit of a difference. If your LVEF declines by more than 10%, and a little bit of a leeway, because remember, this is dysfunction and reversible. So we have a leeway. Instead of 50%, we let them go down to 40% if need be. And if they develop heart failure or decline in LVEF, here's the difference again. You discontinue it temporarily, start your ACE inhibitors, beta blockers, cardioprotective therapy. You repeat an echo in 4 weeks, and if the LVEF has improved, which it should if it's dysfunction, you can re-challenge them with trastuzumab. So that's the difference between anthracycline monitoring algorithms and trastuzumab of type 2 cardiotoxicity. Difference is dose-related, the frequency of echo monitoring, and the fact that you can or cannot re-challenge them. Remember, nothing is set in stone, however, right? So this is historical classification, type 1, type 2. After having, hammered this into you, the definition and the fact that it might come in your boards, I'm already fast forwarding to the iPhone XS, okay? We've left this behind, and I can't even tell you how many mechanisms there are beyond anthracyclines and trastuzumab of cardiotoxicity. And let's leave type 1 and type 2 behind. And I'm not going to, don't worry, it's not a horror story. I'm not going to go through the different mechanisms. I'm just going to touch a little bit just to give you a little flavor of how not one size fits all approach can help in this, right? So cyclophosphamide has this intermediary, which is cardiotoxic, called acrolein, which goes through endothelial capillary damage, and lots of new emerging herbs and piperine and cucuramine are being studied to disrupt acrolein and prevent cytoxin cardiomyopathy. TKIs, the tyrosine kinase inhibitors, are vasculo cardiotoxic drugs, as I call them. And they mainly act through VEGF inhibition, which basically makes them go into horrible vasospasm, which explains the amount of hypertension that these people have. They get very thrombotic, again, through VEGF inhibition. They basically inhibit their PTGRF, which causes CHF, so completely different mechanism, right? Touching a little bit of new kids on the block, which you may or may not have heard of until you're floating around on the 11th floor. And this is where I come in, and this is one of our colleagues who was an ex-physician at Sinai. He was a 75-year-old doctor who had non-small cell cancer, and he was treated with this drug, and the reason why I'm saying is that you may or may not have heard of these new kids on the block, this drug called pembrolizumab. Okay, and he comes in with sudden shortness of breath. Remember, he has metastatic lung cancer. And so he comes into the ER very short of breath. We're thinking BE, CAD, lung cancer, what is it? Troponin is 36. Horrible T-wave inversions is EKG. First thing, of course, you rule out PE. Yay, no PE. And then the CT shows that the lung nodules are the same as before. So hey, no progression of disease either. We end up cathing him. Cath, normal coronaries. And his echo, which was normal like a few months ago when I'd seen him, was normal. And now he has this new decline in LVF to 35% with a troponin of 36. And as we're doing the echo, he goes into complete heart block, and we transfer him to the CCU. What is this drug, pembrolizumab? It's a designer drug because our ex-president, Jimmy Carter, got it, and it saved him. He's still around from his brain cancer thanks to this fabulous designer drug. And really, I'm not belittling it by calling it a designer drug. It's literally a lifesaver for so many metastatic and lymphatic malignancies. And here's where I'm going to show you again a nice basic science slide to make things easier for you. And right now, we have about 8 of these approved, and this belongs to a fabulous new class of drugs, the last class that I discussed, the iPhone XS class, right? And these are called the ICIs, or immune checkpoint inhibitors. And I want everybody in this room to have a little higher index of suspicion and a little awareness of these drugs, because, let me walk you through this. Immune checkpoint inhibitors, so this is the cancer cell, tumor cell. And we have our mechanisms in place. Our immune system should fight off any foreign cells, right? So we have our T cell mechanisms in place that should be able to kill off these cells, except the fabulous tumor cell has this life insurance policy called a checkpoint inhibitor. This checkpoint inhibitor is not for us. It's for the bad guy, the cancer cell, right? So the cancer cell has these beautiful checkpoint inhibitors. So we have certain receptors on our T cells which help to recognize these tumor cells, like programmed cell death, and then there's CTL4 and a lot of other receptors by which it locks into the tumor cell and should kill it. Except that our fabulous tumor cell has these checkpoints on it, like the programmed cell death ligand 1, which goes and locks into our T cell receptors and prevents it from sucking in the tumor cell and destroying it. So guess what? We developed cells that can break its insurance policy. And these are therefore called the immune checkpoint inhibitors. They are splicing off the tumor cell's checkpoint. And so we have PD-1 ligand inhibitors, which can attach to the PD-L1 on the cancer cell or to the PD-1s on our T cells and prevent this insurance policy from happening for the tumor cell. And as a result of it, the T cell can lock into the tumors and kill it. So there are a whole class of either PD-1 inhibitors or PD-L1 inhibitors, and there's also another cell called the CTL4 receptors on the tumor cells. So depending on what it attaches to, it basically breaks off this life insurance policy of the tumor cells and helps to kill it. And except, remember, it's using our own immune mechanism to attack more, right? So our immune system ends up attacking our own bodies as well. And there's a whole slew of side effects. And literally, you start from cerebrum to the foot maybe, and add an itis to every organ we have in our body. And these immune checkpoint inhibitors cause itis from cerebritis to colitis to thyroiditis to adrenalitis to you name it, they call it. Except, hey, I'm here for a cardiology talk, so let's talk about myocarditis, which was actually the least of our concern. And in pre-marketing studies, it was about 0.1% that the incidence of myocarditis was seen. I was like, don't worry about it. Hey, it's not an anthracycline. Except, fast forward to 2016, that there were two post-mortem studies came out of Vanderbilt that reported post-mortem studies of two patients who had undergone the same drug, similar drugs, PD-L1 inhibitors, nivolumab and ipilimumab, and they basically noticed this fabulous immune-mediated myocarditis that killed them, almost like a giant cell myocarditis, kind of fulminant cardiomyopathy that killed them within days of them getting this drug. They went into tachyarrhythmias and heart blocks and like a full fulminant T-cell infiltration under the microscope. Luckily, this article was 2016. Remember, I saw Dr. Coleman in 2017, so I had the Monday morning quarterbacking to help me, and I said, oh God, he's got into complete heart block, new cardiomyopathy, no coronary disease, no PE. This is Keytruda-induced immune-mediated myocarditis. And so I had the NEJM article to back me up where the patients died because they were given 1 milligrams per kg of methylprednisolone. I'm like, I'm going to bombard them with something bigger. And so I bombarded him with 2 milligrams per kg of methylprednisolone. Same admission, repeated an echo a week later, his EF improved. Unfortunately, heart block was irreversible, so we ended up giving him pacemaker. He was discharged to hospice, and he died 7 months subsequently. Got a beautiful letter from his wife. He died in hospice in good spirits. And so we became part of a registry. This was the first article coming out of this registry where we've pulled together with MSKCC and Brigham, and we put together this data where we've started seeing these immune checkpoint inhibitors, which is such a mana for these end-stage oncological patients. And we've seen in our registry data so far, and trust me, this number is rising, that myocarditis is more, immune-mediated myocarditis is more common than we thought initially. And here's the caveat, and this is why mechanisms are so important to understand. Guess what? On our registry data, we saw that most of this cardiomyopathy, these patients can get these drugs for years, right? So most of this immune-mediated myocarditis was occurring the first 3 months. Echo doesn't pick it up. Your LVEF might decline much later. MRI doesn't pick it up unless you do the MRI after 5 days. Guess what is the best screening tool for ICI-induced myocarditis? Good old EKG and troponin. Good old EKG and troponin was positive in plus 90% of these cases. So all we need to do is when they come in first 3 months with ICIs, asymptoms of course, but get an EKG and get a troponin on them after every dose that you give them, and you might be able to pick up subclinical myocarditis. Whether or not we can re-challenge them, we don't know, but based on our registry data, this is what we suggest, that if they have an elevated troponin abnormal EKG in the first 3 months after ICIs, please consult Cardio-Oncology. Then there are drugs like carfilzomib that you might have heard of, which is used widely in multiple myelomas. It is a game changer in myeloma patients, right? And we started noticing a huge amount of heart failure, ischemia, hypertension, dyspnea, and these are like initial trials which weren't even designed to pick up cardiotoxicity, and we noticed this in the ASPIRE, etc. trials. And so I had this fellow rotating with you, had his own basic science lab in Detroit, and I told him, like, we have to understand the mechanisms of the drug, take it to your lab, feed it to the rats, and see what happens, right? So he took it in the rabbit models, and basically we saw this intense amount of acetylcholine endothelial-dependent vasospasm, similar to TKIs, but intense amount of vasoconstriction tone, which we feel is a mechanism of action of carfilzomib, where it causes heart failure, hypertension, chest pain, shortness of breath, just because of the increased coronary resistance, vascular tone, and vascular reactivity that we saw in these studies. And we were actually ended up being cited in a lot of subsequent carfilzomib cardiotoxicity data. And therefore, when people come to me with carfilzomib toxicity, I bombard them with vasodilators and sympatholytics with understanding the mechanism of this. So remember, this is just a little blurb of how different cardiotoxicities happen. I do want to put in like 2 slides about all of you who are rotating through ICU, and you're going to see something called cytokine release syndrome, or CRS. And you're going to hear this word CAR-T therapy, right? Again, immunotherapy has blown the oncological world, and it's also blown my world because I end up dealing with the cardiac effects of this. So let me again walk you through a very busy slide. So CAR-T therapy is used in a lot of advanced lymphomas, leukemias, and myelomas, right? These people have failed all kinds of chemo. It's life-saving for them, end-stage life-saving. So we take the patient's own T cells, right? We take them out, take them to a lab, and we genetically modify them by introducing an inactive virus into the patient's own T cell, making the patient's T cell express something called CARs, which are basically chimeric antigen receptors. And now our T cell becomes a CAR T cell. And these are beautiful CAR T cells because these CARs on the surface of the T cell, when introduced, when multiplied and reintroduced back into the body of the patient with the leukemia, lymphoma, and myeloma, now specifically targets the cancer cells and kills them off, because these CARs are specifically designed to be antigenic or antibody to the antigenic cancer cells, right? Beautiful system, beautiful mechanism, life-saving, except we are introducing these super activated, ready-to-go CAR T cells in our body, which will activate our cells and our immunotherapy as well. And it's basically notorious for an IL-6 mediated cytokine release syndrome. It's basically like the cousin of a horrible septic shock, okay, vasodilatory shock. And as a result of it, myocardial depression and cardiomyopathy, similar to, stress cardiomyopathy, can occur. And the treatment here is, besides pressors, etc., is you bombard them with an IL-6 blocker. Since it's IL-6 mediated, you bombard them with tocilizumab, which we do have formulary in Sinai, and steroids. And then, of course, standard heart failure therapy when their blood pressure is stable. But the caveat here, and you'll see a lot of them come to me for clearances before, and you do not make the mistake of doing this. I know you won't, but because of the CRS, these people undergoing CAR-T, the potential of having CRS, their blood-brain barrier and vascular beds are very friable. So they cannot be on anticoagulation. So God forbid they were on AFib or whatever else. You can't anticoagulate them, and you can't give them dual antiplatelet therapy. And we discontinue that for about 7 to 10 days before CAR-T therapy. So just to put your radar out, it's like, what's CAR-T and why am I discontinuing the Eliquis, just for you to know that. And also remember, Takotsubo's, which I'm sure everybody around this room is very familiar with, the broken heart syndrome. It doesn't just happen at traffic stops and heartbroken women. It happens a lot in our oncological patients. It's a very stressful situation. So this is the typical apical ballooning syndrome, named after the Japanese octopus pod. I don't know how many of them still use it, but the LV gram and the echo still looks where the rest of the heart's okay, but the apical segments of the left ventricle balloon out like an octopus pod. And the incidence of Takotsubo's in our cancer patients is very high. In fact, they actually did a 5-year nationwide study in cancer patients, and they noticed that about 1/3 of cancer patients can have Takotsubo's cardiomyopathy. So when you don't find anything, they don't have CAD, they don't have PE, they're not, getting cardiotoxic chemotherapy, there's always a possibility of Takotsubo's in these patients. So I hope I've confused everybody around this room. And so we're talking about good stuff now. Here, the horror stories are over. Every drug is horrible. Every drug's mechanism is different. I don't understand this basic science stuff. Let's try to prevent it, right? And that's where you guys come in. And really, the prevention is key, and you guys are key, because they're going to come to me only if you guys send them to me and my colleagues, right? So understanding cardiotoxicity and keeping your window of suspicion very, very broad is very important. And really, whether it's anthracyclines, the risk factors are pretty much the same. It's very similar, where we made it a little bit broader than framing it, but really, it's all common sense stuff. Hypertension, radiation, coronary disease, age greater than 65, whether it's HER2 therapy or VEGF inhibition or anthracyclines. The point I want to drive home is, Please don't not treat their dyslipidemia, their hypertension, their CAD. Just because somebody has cancer doesn't mean you give them a death warrant from your side for treatment, okay? Everything goes hand in hand. This is not the time where we say, oh, poor thing, let them go through chemotherapy, everything's going to interact with things. I don't want to start them on a statin. I don't want to start them on a beta blocker. This is the time when you start them. You treat their heart failure, you treat their latent CAD, you treat their dyslipidemia, because not only all these concomitant things add to their cardiotoxicity, secondly, they're going to beat the cancer. Remember, most of them are going to beat their cancer and they're going to live longer. And then you're going to have to deal with the late cardiotoxicity and the late cardiovascular effects of these patients, right? So please treat them. And what tools do we have to detect it early, right? So patient education is key. And really, a lot of my time goes in counseling these patients, going through the scenarios of what the incidence and possibilities of them developing cardiotoxicity is. And patient education is key. Let them know, hey, be aware of your symptoms. Because you know what? We don't do a good job of identifying symptoms. And maybe we don't have the time, we don't have the patience. But really, if you leave it to the patients, and believe it or not, nurse practitioners, they're excellent. If you leave it to our little helpers and our patients, they do a much better job of reporting symptoms and picking up early cardiotoxicity than we do of it. And biomarkers, we love sitting around the computer. We'd rather sit around computers and analyze data than talk to a patient. So yay, biomarkers help. What about BNP? Can BNP protect future heart failure? Data is kind of equivocal. We do know at the higher the BNP levels, it probably have worse outcomes later on. We know they have higher MACE, but we're not sure if it predicts decline in LVEF. Troponin, however, is a little bit more robust predictor, right? And elevated troponins are probably predicting cardiotoxicity earlier before the LVEF declines. Echo, yay, echo, of course, huge amount of data with echo. And remember the definition of CT-RCT, 10%, 55%, right? Problem with LVEF, it's already too late. If you're going to hang your hat on the LVEF declining for cardiotoxicity, the ship's already sailed. And not just that, we are very bad at giving an exact number of LVEF to our colleagues, our oncology colleagues. And trust me, I've like half my emails and calls going saying, the EF was 75% like a month ago, now it's 65. What do I do? It's a 10% decline. And I take responsibility for this in the sense that all our colleagues, and this is really a meta-analysis of patients undergoing cancer chemotherapy, and how there's a huge, no matter how I calculate the EF, and these are different methods, biplate symptoms, with contrast, without contrast, triplate symptoms, no matter how I calculate the LVEF, there's a huge amount of inter and intra-observer variability in predicting LVEF. And I could go into the room, blind me, 45 minutes, I might read plus minus 2%, 5 percentage points in the same patient's EF, right? So the only method of LVEF reading that has the least inter-observer variability is 3D LVEF. How many of our echo reports have 3D LVEF? 0. Probably just a few research studies. So really, there's a lot of inter and intra-observer variability, and already the ship has sailed. So the two things which are able to predict cardiotoxicity or LVEF decline are A, troponin. If troponins are positive, they might predict that 3 months later the LVEF is going to decline. And there's something called strain, and you might see this in our echo reports. Strain might predict a decline in future LVEF. So what is strain? Oh my God, another horrible word, right? So let's just say that strain is a good word. Strain basically means deformation. And the heart really in systole deforms, so it's a good thing. And the healthier the heart, the more vigorously it's going to deform in 4 axes. In a longitudinal axis, in a circumferential axis, in a radial axis, and in a transverse axis. So it's like a swish going on in 4 different vectors, and that deformation or shortening during systole is a good thing. The more vigorous and healthy your heart, the better the strain is going to be. So let's just stick to longitudinal strain because it's been validated in cancer chemotherapy patients. So say this is your sarcomere in diastole. It's 8 centimeters long from base to apex, and it deforms, good word, into systole in 6 centimeters. So there's a 2/8, 25% deformation in the longitudinal axis. This is a good vigorous heart. So if this was affected by chemotherapy, this deformation or shortening in the longitudinal axis, i.e. longitudinal strain, is going to become less and less. So if I put it in a bullseye map for different segments of the heart model and put it in an average number called GLS, So you're going to see this in our echo reports called global longitudinal strain, where all the segments of the heart are represented. So any number above minus 18, if it deforms by more than minus 18%, it's a good thing. It's a good, vigorous heart. So all these numbers, minus 28, minus 31, 32, great. Minus 8, not good. See how it can pick up segmental variations as well. And we've seen in a meta-analysis of 33 patients that this is able to predict a decline in LVEF even before the LVEF declines. And a GLS might be one of the earliest markers of cardiotoxicity that we can get from echoes. And for example, there's a patient who started off with trastuzumab therapy, normal GLS of minus 25, averaged out, and then got trastuzumab therapy 3 months later, and the GLS had declined to minus 14. And if your GLS declines by more than 15% over the patient's baseline, that means an abnormal, to a point of less than minus 18, that is an abnormal GLS, and that might predict future decline in LVEF. So look at it as a crystal ball for future cardiotoxicity, right? And so the ASC, taking it beyond its crazy definition of CT-RCD, now, besides CT-RCD, has put it in that if your GLS declines over baseline by more than 15%, that might indicate subclinical LV dysfunction. Okay, great. What do we do with this stuff? What do I do? Tell them to stop chemotherapy? So, well, we're working on it, but there might be data emerging, such as the upcoming Sucker trial, which is suggesting that maybe guided by abnormal GLSs or declines in GLS, if we initiate cardioprotective therapy, ACE inhibitors and beta blockers, we might interrupt or prevent future cardiotoxicity and be able to, without fear, give these patients cardiotoxic chemotherapy. So, yay, everybody gets a pill, right? So what pills should we pop? Huge slew of data, all small trials. Caveat, I'm putting it in a busy slide. I'm not going through all of this stuff. Smaller trials, 30 patients, 40 patients, 80 patients at best, of primary prevention. Primary prevention. The LVF hasn't declined. We're giving them cardiotoxic chemotherapy, losing anthracyclines and trastuzumab. And there's data for ACE inhibitors, ARBs, beta blockers. The Overcome trial was studied in bone marrow transplant patients where we bombarded people, all comers, without hypertension, without heart failure, Corrigan and enalapril. And those who got Corrigan and enalapril versus who don't had less decline in LVEF after BMTs. The PRADA trial came up 2 years ago, which showed candesartan was primary prevention in breast cancer patients receiving anthracycline trastuzumab. Metoprolol did nada, nothing. CESI trial with carvedilol did not reduce events, but there was a reduction in troponin levels and diastolic dysfunction. Bisoprolol has shown to be consistently preventative. Nebivolol emerged in the Manticore trial as well. And so basically, let me synopsize the whole thing into one slide that, first of all, please risk assess them and see whether we can treat, and we should treat, the cardiac risk factors. Decide on the drug and the dose. Try changing the infusion regimen. Try to think about particular protective therapies like dextroxazone and acrolein inhibitors and Cytoxan. Maybe you want to switch dosage forms, and I'll go over Doxil in 2 seconds, ACE inhibitors and beta blockers. So there's a lot of ways of preventing cardiotoxicity, right? And I wanted to touch a little bit on the Doxil story. So Doxil, and you must have heard of it in sarcoma patients, is basically doxorubicin, but it's encapsulated in liposomes, so it becomes a big molecule. It's the same doxorubicin, so it's able to go and kill your cancer cells, but it's a very big molecule, so it's not able to penetrate into the preformed vascular beds of the heart, which are narrower, versus the vascular beds of a cancer cells are huge. So they enter into the cancer cells, but they're not able to enter into the myocardium just as well, and so the cardiotoxicity is better. So alternatives are there. There's a preventative role of statins that we're studying now. So don't be afraid of putting them on a statin unless there's like huge drug interaction. Flu vaccine, don't forget, and this came out of our registry data from the ICIs, that patients who received a flu vaccine within 6 months of them having received one of the checkpoint inhibitors had less myocarditis, had less immune-mediated cardiomyopathy. Again, we don't know the exact mechanism, the whole immunotherapy stuff, but give them their flu shot, give them the ACE inhibitors, their beta blockers, their statins, and don't forget other cardiotoxicity. And since we're short on time, I'm just going to give you a little teaser of all the slides. I'm going to open up a Pandora's box, give you a whole slew of drugs that cause ischemia, with just one caveat. Remember, just because patients with cancer have low platelet counts and they bleed, does not mean that it can't get ACS, okay? Thrombocytopenia is not a protectant. You do different things to protect them in ACS. We might use a radial approach. We might use bare metal stents. There are new strengths coming in. Aspirin is okay to use as long as their platelet counts are okay, more than 10,000. I know it scares a lot of people around this room, but yes, I've used aspirin in people with platelet counts 20,000. Clopidogrel, a little bit higher platelet counts are needed, and the other antiplatelet agents you want to have platelet counts higher than 50,000. And newer drugs such as polymer-free stents are coming up where we might need just 1 month of dual antiplatelet therapy and get away with it. And remember, so just to give a synopsis, if you're just using aspirin for primary prevention and the patients are thrombocytopenic or undergoing drugs that cause thrombocytopenia, please stop the aspirin, okay? Bare metal stent, it's okay to continue aspirin for platelet count for 20,000 for sure, in some cases more than 10,000. If you have a drug-eluting stent, please try to delay thrombocytopenia, bone marrow transplant, etc. for 30K at least for 6 months so that the platelet counts don't go below 30K. If you're using anticoagulation, please stop or half the dose of Lovenox, low molecular weight heparins at 20,000, and you have to dose adjust it. And of course, I'm always there available to answer questions about dose adjustments, etc. But remember that not only does cancer causing clotting, a lot of the chemo causes thromboembolism as well. And these are latest slides that came out in the last 6 months. So everybody knows from the CLOT NEJM trial, right, that low molecular weight heparins are superior to Coumadin. So Coumadin for cancer patients out, right? Drug interactions make some clot again. We know that. And we saw in the sub-studies for apixaban, rivaroxaban, and dabigatran that NOACs are actually probably superior to Coumadin in thromboembolism, right? But we weren't sure if the NOACs hedged against low molecular weight heparins are equal, better, worse, or not. There was a chest meta-analysis in 2015 that suggested that maybe NOACs are superior to Lovenox and low molecular weight heparins. And so, fast forward to 2018, last year, we had 2 trials in NEJM. One was a SELECT-D trial in the Hokusai. You guys might want to read up on that. One studying edoxaban versus dalteparin, and the other one rivaroxaban versus dalteparin. And guess what? Yes, less recurrent VTE with NOACs, but much more bleeding. And much more bleeding in which patients? GI and GU cancers. So here's what I do as a rule of thumb, is that I love NOACs, much more easier to use than low molecular weight heparins, and of course, less VTE. But if they have GI and GU tumors, I stick to low molecular weight heparins. But if they don't have a GI GU tumors and I'm using it, then it's probably best, it's okay to go with low molecular, with NOACs. And we recently, just 4 weeks ago, 2 trials came out in NEJM, the AVERT and the Cassini trials, and this is primary prevention. It's not VTE treatment, it's prophylaxis in talking patients, in cancer patients, not in patients. And basically, AVERT was apixaban to prevent VTE, half dose, not 5 BID, 2.5 BID, which lowered the risk of prevention of VTE over 180 days. And rivaroxaban was also 180 days, half dose again, 10 milligrams once a day. It did not statistically lower VTE incidence or death due to VTE, but there was a reduction, a trend towards reduction in VTE, and the risk of major bleeding in both studies was twice, so 2% versus 1%. Not horribly high, but remember we're using prophylactic doses here. Huge amount of drugs causing bradycardia. Please don't put in pacemakers into these patients. Just go through the list of drugs that cause bradycardia. Arsenic is a big one for QT prolongation, but there's a whole list of QT prolonging drugs. Atrial fibrillation causing drugs. And remember, it's a tough group to manage. Not only can you not apply CHA2DS2-VASc scores to them, they bleed more, they clot more. We have to think outside the box. And I want to show you a horrible drug called ibrutinib, which is like Jekyll and Hyde. Fabulous drug. Used in a lot of lymphatic malignancies. But if somebody with ibrutinib goes into AF, please call me or call one of my colleagues, because they have a huge incidence, about 20% incidence of atrial fibrillation, and you cannot give them half the drugs. You can't give them amiodarone, you can't give them diltiazem, you can't give them anticoagulation with Coumadin. There's a whole lot of drug interaction, bleeding, clotting, etc. And it's a very difficult situation to treat when somebody with ibrutinib goes into AF. A whole lot of drugs causing pericardial effusion, and 2 seconds on radiation-induced heart disease, which less amount of my patients that I see, but don't forget that if you've been exposed to left chest radiation, whether it is mantle radiation or breast radiation, if patients have exceeded 30 gray units cumulative, they are going to develop, high chance of developing radiation-induced heart disease. Again, board question, very rare to happen immediately. Most of the effects, the 2 big ones, CAD, and radiation-induced valve disease happens after 10 years. So CAD happens after 10 years, and radiation-induced heart disease usually happens after 20 years. And so that's where the screening should start. So we tell people to come in for an echo between 5 to 10 years if they are high risk, and after 10 years if they are low risk for echo and for screening for CAD and radiation-induced heart disease. So let's now relax, and all the bad stuff is over. Now let's see my patient's poor bad stuff. And this is a patient with routine, I have very few oncological emergencies, but when somebody has, this patient had an abnormal echo, sent for a TE, and then they called me panicking. There's this whole huge, it's a TE study. This is the right atrium, tricuspid valve, right ventricle. This shiny structure here is a port. Patient had metastatic HER2 breast cancer undergoing trastuzumab. Huge floating around structure here. We don't know whether it's thrombus or a cancer, right? And so we actually took the patient to the OR because of this huge embolic potential. We can't wait for anticoagulation to act. Luckily, it turned out to be a thrombus, and the patient had a sternotomy, but luckily we had to. It was a huge thrombogenic potential. This was a sadder story, a patient with angiosarcoma of the liver with a huge pericardial effusion. You can see this echo-free space here. But what's more scary than the large pericardial effusion is this is the right ventricle, this is the left ventricle, is this amount of gunk sitting here in the right ventricle, and this kind of cavitation almost, and we're kind of worrying, is this cancer inside the right ventricle, or has the cancer gone through the RV free wall and is now causing this pericardial effusion? Luckily, we gave contrast to this patient, and the contrast, which is here, does not extravasate into the pericardial space. So luckily, this was a separate pericardial effusion and not a rupture of the RV free wall. So just to synopsize, everybody hopefully in this room can distinguish between type 1 and type 2 cardiotoxicity, and the rest you leave to me. Should know early detection, prevention, monitoring, treatment is key. Surveillance protocols should be established, and be aware of these, especially the non-CHF cardiotoxicities. Don't forget your radiation patients. And we do understand a lot of the cardiotoxicities. We just don't know whether prevention and treatment can be uniformly applied because it's not a uniform mechanism of action. And maybe some trials like the Sucker trial will let us understand if tools such as GLS can be used to intervene earlier. And what is the cost of it all? And are we allowed to say no to patients getting this chemotherapy, right? Just too many mechanisms, not enough in the guidelines, though we have a lot. And by the way, the ACC, AHA are lacking in that. And again, the cost factor is huge, right? So I told you about the slide with the HER2 positive trastuzumab therapies. So everybody gets an echo at baseline, and every 3 months when you're on trastuzumab, that's 5 echoes per year, right? For a patient with HER2 positive breast cancer. I'll just show you the math for one of them. So Medicare reimburses us $570 for an echo. And there were about in 2017, there were about 250,000 cases of HER2 positive, of breast cancer, out of which 63,000 were HER2 positive. So I'm giving them trastuzumab, right? And so that means per patient, just the echo part is costing us $3,500. And does every patient need like 5 echoes, 4 echoes a year? What if the echoes, say, in the beginning and like somewhere in the middle were fine? If you take away 1 echo for these patients, we can save about $36 million per year on these breast cancer patients. So it's not it's easy said and done based on these smaller trials. So let's intervene, let's get GLS, let's put them an ACE inhibitor and beta blocker, let's follow them an echo in 4 weeks. But really, the cost-benefit analysis, I know every patient's important, and that's why pharmacogenomics and really personalized medicine and going by who is susceptible, who needs more monitoring, who needs more intervention is where we're heading towards. And really, people in this room, basically, who should be referred to cardio-oncology, you know the people with higher risk factors. You should be slightly aware of the cardiotoxicities while they're undergoing treatment. And don't forget the late cardiotoxicities, patients who've been exposed to anthracyclines, radiation, etc. And so how are we doing in cardio-oncology here? Huge amount of patients. We saw close to 3,000 patients last year. We've initiated a lot of monitoring protocols, GLS protocol you're going to see in our echo reports, routinely in patients getting chemotherapy, a lot of research activities going on. And if anybody wants to go to resources, we have a couple of chapters and a lot of books. And from that roller coaster ride in the beginning slide, hopefully this roadmap helps you clear a little bit of the cobwebs I introduced. Thank you, and open for questions.
We had a little bit of a late start, so I'll invite everyone up for questions, and let's thank Dr. Sahni for